Good evening, Dr. Srinivasan.
Good evening, sir.
Good evening.
Am I audible, sir?
Yeah.
Yes, sir. Yes, sir. Yeah, Chetan, you can confirm once it is open for delegates so that we can start.
Yes, sir. We are live now. You may start now.
Okay. Yeah, Ellen, sir, shall we start, sir?
Yeah.
Yeah. Thank you, sir. Thank you. Good evening, doctors. On behalf of Alchem Laboratories, India's fifth largest pharmaceutical company, I am Balaji. Take great pleasure in welcoming all the eminent doctors who have joined us for today's panel discussion. Doctor, today's panel discussion will be on titled Galaxy of Experience on Rosuvastatin. Doctor, at Alchem, it has always been our endeavor to partner with healthcare professionals, and we will continue to do so even in these challenging times. To help us to navigate through the entire meeting, we have with us today Dr. Elilan sir, who will be our moderator for today's panel discussion. Welcome, sir. Let me take this opportunity to give a short introduction about Elilan sir. Dr. Elilan sir is a senior consultant interventional cardiologist who is practicing at Madras Medical Mission, Chennai. Doctor has graduated his undergraduation and post-graduation from KMC, and he is practicing in Madras Medical Missions for more than 10 years now. Doctor was associated with earlier as a professor of cardiology at Madras Medical College, where he has done his post-graduation DM and DNB. Doctor has also done a 2 years postdoctoral fellowship in interventional cardiology at Escorts Heart Institute, Delhi. And Dr. Elilan sir has got close to 34 publications and 72 presentations in various national and international conferences. And he was also a part of various cardiology trials. And Doctor has been awarded GB West Gold Medal and RV Rajam Gold Medal for proficiency in medicine by MGR University. So with this short introduction, I once again welcome Elilan sir. Welcome, sir. And I take this opportunity to welcome all the panelists for today's meeting. Firstly, I'd like to take this opportunity to welcome Dr. K.N. Srinivasan sir. Dr. K.N. Srinivasan sir is a senior consultant interventional cardiologist who is practicing at Apollo Hospital, Chennai. Doctor has done his post-graduation in the year 2003, and he is practicing as a cardiologist for more than 17 years now. Doctor has got close to 15 publications in peer-reviewed journals. Also, Doctor has got various academic achievements. He was also a recipient of FCSI and FPSC in interventional cardiology. So, welcome, K.N. Srinivasan sir. Take this opportunity to welcome the next panelist, Dr. Badrinath sir. Dr. Badrinath sir is a senior consultant physician and consultant in cardiology who is currently practicing at Manakula Vinayagar Medical College and Hospital, Pondicherry. Doctor has done his MBBS and MD in the year 1999, and he is practicing in Pondicherry. He has also done his postdoctoral training in cardiology in the year 2008. Also, he has done prevention and management of diabetes and cardiovascular disease course from France, and also he has done a basic course on echocardiography, and he is also a recipient of various fellowship from Royal College of Physicians, and he is practicing at Pondicherry for more than 20 years now. Welcome, Badrinath sir. Let me take this opportunity to welcome the next panelist, Dr. Nandini madam. Dr. Nandini madam is a senior consultant cardiologist. He is practicing at Vellore. Doctor has done her undergraduation MBBS from Chengalpet Medical College and MD from Coimbatore Medical College, and post-graduation at Vijaya Hospital, Chennai. She is currently a consultant cardiologist practicing at Mummy Hospital, Vellore for the past 13 years. Doctor is also State IMA Women's Wing Secretary in the year 2015 to 2017. Welcome, Nandini madam. Let me take this opportunity to welcome the next panelist, Dr. Mohan sir. Dr. U.V. Mohan sir is a consultant diabetologist who is practicing at Mohan Clinic, Padi, Chennai. Doctor has completed his MBBS in the year 1986 from Kilpack Medical College. Also, he has done his diploma in diabetology in the year 2008, and close to more than 15 years, he has got a clinical experience in the field of diabetology. He is currently practicing at Padi as a senior consultant diabetologist. Welcome, Mohan, sir.
Thank you, sir.
So with this short introduction, I will hand over the session to Eliland, sir. So you can set the context for the webinar. Over to you, sir.
Thank you. Before starting the questionnaire, I'll just present some 5-6 slides as introduction to the discussion, and then we'll go.
Hello, sir. Doctor, sir, our indoor meeting that around.
So, today we are going to discuss about the galaxy of experience with Rosu. Can you unmute Balaji the mic from where we are receiving that voice? Okay. Statins are now the most popular lipid regulating drugs used worldwide because of its consistent and strong track record in bringing down cardiovascular morbidity and mortality. It reduces CAD events by 25 to 30%. Statins has a $20 billion market share. These are the variant statins that was introduced. The first statin to be introduced was lovastatin in 1987. Then came pravastatin and simvastatin in 1991. Then fluvastatin in 1993. Atorvastatin in 1996. Serivastatin in 1997. And rosuvastatin in 2003, and then pitavastatin was the last statin to be introduced. So now we have an experience of almost 33 years of using statins. Among these various statins that we have, lovastatin, pravastatin, simvastatin, fluvastatin are all statins with bile potency. So you can use only for low intensity statin therapy, you can use this. So that is why now it has become obsolete. We don't use these drugs. Serivastatin was one statin which got banned because it utilized more than 3 CYP pathways. So it had more drug interactions. It caused many fatal rhabdomyolysis, and hence the drug was banned. So ultimately now we have atorvastatin, rosuvastatin, and pitavastatin which are in use. Of these drugs, again, pitavastatin can only be given for mild intensity or moderate intensity statin. You cannot give it for high dose statin therapy. So ultimately, we are left with only 2 statins, atorvastatin and rosuvastatin. So now among these 2, which one is best? Which one should be used frequently? We'll be discussing today. And we all know how it is a rate limiting, the statin's mechanism of action is it inhibits the HMG-CoA reductase and thereby prevents synthesis of cholesterol. That is how it reduces LDL. But now we are also more interested in the pleiotropic effects of statins, which is because of preventing prenylation of proteins, which leads to apoptosis, inflammation, endocytosis, etc. So now even this is very important, and the use of statins in acute coronary syndrome is not because of reduction in LDL, because before reducing LDL, we see the benefits. It is only because of this prevention of this prenylation of proteins of this RAS and Rho GTPases. Now, initiating statin is like catching a tiger by its tail. Once you start therapy, it should be taken lifelong by the patient. So one should always discuss with the patient that if I start this drug, you have to take it lifelong and you cannot stop it in between. Only after patient agrees, we should take. In secondary prevention, you have to introduce it, no other go. But in primary prevention or people with low risk, moderate risk, one should discuss with the patient. Why? Because discontinuing statin is worse than not taking statin. See, people who discontinue statin are at the highest, the lowest survival. But whereas patients who continue statin regularly are at the higher end and they have a good survival. People not taking statin also are better than people who discontinue statin. So one should never discontinue statin therapy. Now today we are going to discuss about this Galaxy, which is a comprehensive global clinical program comprising 26 studies in over 60,000 patients, the largest ever scientific program undertaken by any statin. And these are the various trials in this Galaxy program. If you look at all these studies, they looked into how much it reduces atherogenic lipid profile, the various components of the lipid profile which were reduced, and the reduction of inflammatory markers. We all know Jupiter trial was the first to show us that by reducing inflammatory marker C-reactive protein, also you can decrease the risk for coronary artery disease. And it also worked in people who had near normal cholesterol levels, not only that you should have high cholesterol. Then this Orion, Meteor, and Asteroid showed to us that it can regress atherosclerosis. These were done by IVA studies where inside the coronaries we showed that it reduces the plaque. And some studies also use the carotid intima thickness to show that it regress the plaque. And then reduction in CV morbidity and mortality were studied by the Aurora, Corona, and Jupiter. So we have such a large amount of studies with rosuvastatin to show that it is the most potent statin and it brings more patients to LDL goals. It is the safest statin, well-tolerated statin, and least side effects. Okay, thank you. So now we'll go to the discussion part. I'll stop sharing my screen. So Balaji, can we see the questions one by one?
Yes, sir. Yes, sir. Sir, you want me to present that PDF file, sir?
Yeah. That PDF file one by one, if you show, we can.
Right. Okay.
I think if there are 5 questions, I'll give one question to each of you so that you come out first with fresh ideas and then let others add to whatever they have regarding that question. So I think till Balaji puts the first question, I'll read it out myself. In adults with clinical atherosclerotic disease, that is people with established coronary artery disease, peripheral arterial disease, or cerebrovascular disease, or patients who are at very high risk of ACVD. What are the magnitude of benefits with statin therapy, and what is evidence with the rosuvastatin? I think Dr. Mohan, you can take this question. Patients with established CVD or patients at high risk for CVD, what do you think should be done for them? Yeah, you are muted, Mohan. You are muted.
So these set of patients definitely need high intensity statin, definitely. Statins as such, we already discussed, definitely in diabetic people, definitely plays a major role, all these things. So in this set of people, naturally, we have to go in for high intensity statin so that the longevity will be much more in these set of people. So I deal more of a diabetic population only, sir, as such.
Yeah. So you will definitely give high intensity statin to them. So what will be your statin choice? Will you give atorvastatin or will you give rosuvastatin?
So as you said, both statins, atorvastatin and rosuvastatin, definitely have tested, withstood the test of time. So there's not much of a difference between rosuvastatin and atorvastatin. But naturally, as you said, rosuvastatin in a mild dose definitely is equal to the atorvastatin in a higher dose. In some set of people where they cannot tolerate, definitely rosuvastatin can be given. Maybe in this set of people, I will go in for rosuvastatin.
Okay, Dr. Badrinath. You are muted. You are muted, Badri.
Yes, sir. Good evening, sir. Highest priority for this patient's atherosclerotic cardiovascular disease, that is acute and prior MI, stroke, those patients who are on stenting or CABG. These patients are required high intensity statin, that is rosuvastatin. I prefer rosuvastatin because less incidence of side effects. With atorvastatin 80 milligram, I just seen few patients got during LFT and myalgia. And moreover, these patients who are high risk and the target LDL is very important in this patient. So high risk group in this patient target LDL, I would like, according to ESA, it is less than 55. According to AHA, it is less than 70. So apart from doing giving high dose statin, if the target LDL is not achieving, I would like to add ezetimibe in this type of patients.
So you would like to give a high intensity statin,
High
rosuvastatin 40, and you would also like to give Isrimab 10 mg so that you achieve the LDL growth.
LDL.
Okay, good. Dr. Nandini?
Yes, sir. I would prefer rosuvastatin in certain individuals who complain of muscle pain and all those. In others, atorvastatin equally. I would prefer a high intensity statin, 20 to 40 rosuvastatin, or 40 to 80 atorvastatin. And especially with a history of pre-existing cardiovascular disease, we need to stress the importance of the drug taken at the prescribed dose. Most of the time, they are told that it is a very high dose and they come down on their dose by themselves. We need to stress the importance of the dosage to them most of the time. That's what happens here in our peripherals.
I agree. Even I have seen, when I prescribe rosuvastatin 40, I mean, their family physician tells that high dose
it is too, and it comes down.
Problem is there. Okay. Dr. Srinivasan, your opinion on treatment for people with high risk ACVD or high risk factor? Okay, Dr. Srinivasan, not there. Okay, so one more question in this is, now people who have established CVD, you are definitely going to give high intensity statin therapy. More now, suppose you have diabetics who do not have very high risk, like their ACVD score is not more than 7.5%. It is less, say 5 to 7.5% or 2.5 to 7.4%. Will you look for risk enhancers, other things among the risk factors, and then add a statin?
Definitely, sir. As you said, diabetes per se itself, there is risk for risk. So being Indian, I mean, is a risk factor, and also a factor like 40 years also a risk factor. And have diabetes, all the more is risk factor. You calculate the risk factor, the family history, whether he has any history of smoking, and all those risk factors. So naturally, if the risk factor is high, definitely you have to add statin for these set of people to prevent future complications. That's what I advise the patient. Even though the lipid level may be normal, diabetic patient, all diabetic patient, naturally, I tend to prescribe statin.
Yeah, I mean, all diabetics should receive moderate, at least moderate intensity statin therapy. And if the risk score is more than 7.5, then you have to give high risk. But in this borderline, newer guidelines have come out with more points to decide whether you need to go for statin therapy. Now, example, like if patient has chronic inflammatory disease, like rheumatoid arthritis, HIV, psoriasis, etc., there also you should give them a statin therapy. If patient has a history of premature menopause in women less than 40, then also you can discuss with the patient regarding statin therapy. Similarly, history of preeclampsia is also considered a risk factor. And then there are certain measurements you can do. Like if you do apolipoprotein B, if it is more than 130, it's a risk enhancer. You can start statin therapy. If your high sensitive CRP is more than 2, then also you can start statin therapy. If your ankle brachial index is less than 0.9, you can start a statin therapy. And lipoprotein A more than 50. And then you can also do a CT calcium scoring. If your CT calcium score is more than 100, then all these are points where even in a patient who has low risk, you can start a statin therapy. Okay, so I think we'll go to the next question. Balaji, can you show us the next question? Now, type of question number 2 is type or intensity of statin therapy. So we know statin therapy is divided into low intensity, moderate intensity, and high intensity. And that is depending on your LDL reduction, less than 30%, 30 to 50%, or more than 50%. So now we'll discuss as to what is the type of intensity statin therapy you will start for your patients. So we'll start with Dr. Badri.
We have to calculate the atherosclerotic cardiovascular risk score. This falls in 1A, as already we have discussed that acute and recurrent MI stroke and those patients who are underwent stenting and CABG, definitely those patients require high intensity statin. The patients with major risk factors, high cholesterol, it is more than 180 milligram, diabetic, tobacco use, and patients who have systemic hypertension, they are risk for 2 to 3-fold increase of atherosclerotic cardiovascular risk. So I will go for moderate intensity of statin. And those patients with the 2A and 2B, that is those patients who are cholesterol of more than 140 or LDL is more than 70 plus atherosclerotic cardiovascular risk, as we discussed as a risk enhancing factor, I'll go for moderate intensity statin therapy, like rosuvastatin 5 to 10 milligram or atorvastatin 10 to 20 milligram.
Okay. Dr. Yuvi Mohan, your opinion on intensity of statin therapy?
I go for, as Dr. Badrinath has told, it depends upon the ASVD score and also about the clinical scenarios. So definitely moderate to intensity depends upon the case as such.
Okay. Dr. Nandini, you would like to add?
The same, sir. Depending on the ASCVD score, the intensity is decided. And depending on the intensity, we can choose either atorvastatin or rosuvastatin, though both equally fair in those without cardiovascular disease.
Sure.
Though the Jupiter trial tells us rosuvastatin is better in bringing down the cholesterol reduction.
Dr. Srinivasan, your opinion on intensity of statin therapy in primary prevention?
The primary prevention, again, it depends, if suppose patient has premature family history of CAD and patient who has diabetes mellitus or patient who has LDL is more than, baseline LDL is more than 190 milligram per cent. So like this, you analyze the points that the patient is having, and if more the points, obviously, he becomes more risk for developing a CAD. So we have to go for high intensity statin. So as everyone pointed out, indirectly it means that you have to go for the ASCVD score and decide whether he needs whether it is less than 5% or 7.5%. Like, what is the score for him, and then accordingly you have to decide about the intensity of statin that he needs.
Okay, thank you, Dr. Smith. Before 2017 guidelines, there was something called low intensity statin therapy also. So it was low intensity, moderate intensity, and high intensity. Only after the 2017 guidelines, they removed off the low intensity statin therapy. They said nowhere low intensity statin is needed. You start with moderate intensity and then go with high intensity. And I think in primary prevention, as said by all of you, mainly the ACVD score or your British Society score, whichever you are using, that decides as to whom should get moderate intensity and who should get high intensity statin therapy. And besides, the LDL goals are also falling lower and lower. ACC, American guidelines say 70, European guidelines say 55. Indian guidelines have even brought it down to 30 in the latest version. So whatever be the goals, I think one has to give minimum moderate intensity statin therapy, and if the risk is high enough, you can go to high intensity statin therapy. Okay, thank you. So we'll go to the next question. Yeah.
Here, I would like to emphasize that antiplatelets, aspirin. If the patient has got increased HSCRP, we would like to add aspirin to the statin therapy. Otherwise, aspirin has got no role in primary prevention.
Yeah. The role of aspirin in primary prevention is slowly dwindling. I remember 15-20 years back when all patients with diabetes and hypertension received aspirin. From that, hypertensive patients were removed. They saw that it only caused more bleeding, but did not give any beneficial effect. So hypertension was removed. No need for primary prevention in hypertension. Then diabetes also, then they said only high-risk diabetics, only patient above 55, only patient with established CVD, or who has high risk for CVD. Only those patients we are giving as primary prevention in diabetes also. So all diabetics don't receive aspirin now. I would agree. But if inflammatory marker like CRP is elevated, now it indicates that patient is at risk, and then I think that is one of the indications to give aspirin as a primary prevention. Okay. So shall we go to the third question?
Yes, sir.
Now this is statin combination. Which statin combination for which types of patients? Now with rosuvastatin, the 4 drugs which can be combined are aspirin plus rosuvastatin, clopidogrel plus rosuvastatin, ezetimibe plus rosuvastatin, and fenofibrate plus rosuvastatin. Now I want each of you to tell me in your practice which of these 4 combination you think is definitely needed, or which combination you think is not needed. So we'll start with Dr. Nandini first.
Yes, sir. Clopidogrel and rosuvastatin I would prefer in a patient with severe APD and gastritis, but they don't tolerate aspirin. Otherwise, the first choice would be aspirin with rosuvastatin. If the patient doesn't tolerate aspirin, then I would go for clopidogrel. And if the lipid levels are achieved with the either moderate intensity or high intensity, I would stick on to these 2 drug combinations. And if the patient is either has an atherosclerotic cardiac disease and his lipid levels are not under control with the maximum intensity rosuvastatin, I would add a estimate 10 mg. If the patient has a very high triglyceride combination along with high LDL, then I would have more than 500, of course, more than 500 triglycerides. Then I would prefer adding fenofibrate along with rosuvastatin.
Oh, okay. Dr. Srinivasan?
Sir, I think
your
all
opinion on this combination?
Combination we'll be using day in, day out. I think all 4 combination has to be there. As Madam has pointed out, we tend to choose the combination which is appropriate for the patient according to the lipid levels and the comorbid problems. So, if patient, generally, from the beginning, I prefer clopidogrel with rosuvastatin combination more than aspirin with rosuvastatin combination. And the second thing is, as Madam pointed out, when the triglyceride level is more than 400, that is the time. But nowadays, I tend to use lipaglyn more than fenofibrate for diabetic triglyceridemia, dyslipidemia. And another thing is this ezetimibe combination, 10 of rosuvastatin, 10 of ezetimibe combination, a lot of companies are having. And sometimes, even with that, we are not able to achieve the LDL goal. Then we tend to, there is some companies have come up with 20 rosuvastatin with 10 of ezetimibe. I think we tend to use that also when we are not able to achieve the target LDL goal in high-risk population.
Okay. Dr. U.V. Mohan?
I see more of a diabetic dyslipidemia, wherein as alluded by Dr. K. Srinivasan sir, we see wherein your LD level is high as well as the TG level is also high. In some of the patients where they cannot afford saraglutaz or lipaglyn, definitely fenofibrate is an ideal combination. In these set of people, I add rosuvastatin for fenofibrate. Only in certain set of people. Some set of people definitely do not tolerate. So I increase the statin dosage, rosuvastatin dosage. In these set of people, a minuscule minority of people, wherein the combination of rosuvastatin and fenofibrate does well as far as economy is concerned and also efficacy is concerned. As far as the combination of rosuvastatin with ezetimibe, in some set of people, where instead of increasing the dosage of rosuvastatin, you add ezetimibe, definitely the results after 4 weeks, definitely there is a fall down of the lipid levels. These are the 2 segment of people I use regularly.
Dr. Badri?
First patient who underwent stenting, we know that we have to use a dual antiplatelet therapy with high dose statin for a minimum period of 1 year dual antiplatelet drug. As Madam says, if the patient is not tolerating aspirin, you can continue with clopidogrel combination. I would like to see LDL target at goal. If LDL target goal is achieved, next I would like to look for non-HDL, residual risk for the patients. And if the residual risk is high, then we can add a phenofibrate. And statin and other optimum drugs that LDL goal is achieved, then we can continue. And other residual risk I would like to look into is decrease HDL and the lipoprotein decrease HSCRP. So if the patient has got increased HSCRP, we can continue with antiplatelets. Lipoprotein decrease, we can add niacin. If the patient has got premature CAD, recurrent coronary events despite of target LDL, then we can continue with niacin therapy.
Oh, thank you, Badri. Like how I see and use these four combinations in my practices. Rosuvastatin with aspirin, I use mostly for patients post CABG or post PTCA after 1 year who are stable, and aspirin only if the bleeding risk is not high. The patient does not have any history of GI bleed. I use aspirin with rosuvastatin. Rosuvastatin with clopidogrel is the most common combination I use because of its GI safety compared to aspirin. And it has also been shown that rosuvastatin and clopidogrel combination is safe. So that I think is the most common combination for antiplatelet with the statin therapy. Coming to rosuvastatin with ezetimibe, what I find is most of the companies come out with the rosuvastatin 10 and ezetimibe 10. So I'm not going to use for people who get controlled with the 10 mg of rosuvastatin. Only after putting 20 or 40 mg of rosuvastatin, still LDL is not coming to goal, then only I use ezetimibe. So I think companies should come up with 20 and 40 mg of rosuvastatin with ezetimibe rather than 5 and 10 mg of rosuvastatin with ezetimibe. So that is one drawback of the existing combinations. If you had higher dose statin, that will be more useful. And then coming to phenofibrate combination, yes, as Dr. Yui Mohan said, definitely Lipaglyn is a newer drug, saroglitazar. But unfortunately, it is not backed by trial evidence. Phenofibrate, similarly, in Western guidelines, does not have any recommendation. They don't recommend at all unless it is more than 500. But the sub-analysis of previous phenofibrate trials have showed that if your LDL, your triglyceride is more than 200 and your HDL is less than 35 or 40, then definitely those groups benefited. So I would not hesitate to start rosuvastatin with phenofibrate if the triglyceride is more than 200 and HDL also is low. Those subsets I give a combination. But of course, one has to be a little careful when you are giving two drugs, statin and a phenofibrate. I think once after 3 months, I check their muscle enzymes and liver enzymes. And if they are normal, then I go ahead. After that, I don't need to monitor all this. Okay. So now we'll go to the next question, Balaji. Question number 4. Okay. Central discussion point is diabetic dyslipidemia. Should all diabetic patients take statin, thereby regardless of the serum cholesterol level? So I think this will give it to our diabetologist as a first choice. Yes, Dr. Yui Mohan, you can take on this question.
As I already alluded in this session, diabetes per se is equal to coronary artery disease equivalent. All diabetic patients definitely are 2 to 4 times risk of CV events. So naturally, all diabetic patients, you have to prevent the risk of CV events. So all diabetic patients definitely after the age of 40 years, regardless of the lipid levels, should definitely take statin. This is what the message is there. Because high risk patient definitely, even though the risk may be less today, tomorrow they can develop high risk in the sense whether we have to see whether the history, family history, about the age, about his lifestyle measures like smoking or drinking or higher BMI, or about his physical status, everything. all diabetic patients more than 50 years, regardless of the baseline lipid level, definitely should take statin. That's what my personal opinion is, sir.
Okay. Dr. Nandini, your opinion?
Yes, sir. When a diabetic, I would prefer initial drug is rosuvastatin, but most of the diabetics have hypertriglyceridemia also. Depending on their levels of triglycerides, a fenofibrate or a lipaglyn can be added along with it.
Okay. Dr. Srinivasan?
Yes, sir. Of course, every diabetic is going to have some amount of, and when we say diabetic, we call it as CAD equivalent. So the level of LDL target comes down. So obviously, they'll be needing a small dose of statin, if not high intensity. And so every patient with diabetes will be on statin mostly. And I'll be preferring rosuvastatin.
Dr. Badri?
I would like to classify diabetes with cardiovascular disease. Avoid cardiovascular disease. That means those patients has got a CVD. Those patients will receive high intensity statin where we have to keep that LDL less than 70. Without cardiovascular disease, if the age is more than 40, we can suggest moderate intensity statin to keep the LDL around 100. And low risk patients with multiple risk factors, so patients with diabetes, with hypertension. I would like to start on moderate intensity statin with control of hypertension with VC inhibitor or
Okay. Dr. Yuimon, they may say that diabetics 40 to 75. If you are above 40, you should receive statin therapy. Now, if you are a diabetic, in India, I think you should be seeing all people less than 40 having rampantly, even in the 25s, 30s having diabetes mellitus. I have seen patients with coronary disease where at the age of 32, 35, they have they developed MI, then developed ischemic cardiomyopathy, LV dysfunction, sever, and before 40, they are no more. So now, how will that apply to India? Now, if you wait for 40 years, by the time his lifespan is gone. So do you think in India, we need some change? That diabetics, even if they are less than 40, you should start statin?
It's a very good question, sir. As already in all seminars you would have participated, and even you have given a lot of lectures also. Being an Indian itself is a risk factor. Definitely, as you said, young age itself, like what they say, even in the fetus also, I mean, it starts from the young age itself. So you have to be very careful. As you said, you see a lot of cases like below 18 years, 19 years, 20 years itself, the lipid levels is very high. So basic thing, you have to educate about the lifestyle modification. Like nowadays, we see a lot of sedentary people. Unlike yesteryears, they do not work physically. So those days they used to work very hard. Definitely, you have the all events only at the age of 60 or 70. So nowadays, with the lifestyle modification, definitely we see a lot of this thing. So taking statin alone is not enough. We have to re-emphasize about the lifestyle modification, as you said about the diet, exercise. Basically, exercise not many people are doing. On top of that, definitely we have to undergo at the age of 30 or before itself lipid profile test, basic test, like say once in a year. And depending on that, definitely we have to discuss, as you said, and then we have to initiate at the early age itself. Before the event itself, if we're going to start, definitely it will prove benefit to the larger sector of people. As you see, a lot of people after developing complications, they land up in hospitals. So you can prevent those set of people.
Yeah. In India, or at least in Asians, coronary disease is premature. It happens a decade earlier. So if my patient is a diabetic and he is less than 40, even if his LDLs are not very high, I look for risk enhancing factors. For example, now even South Asian, race is considered as a risk enhancer. Then you have to start statin. So that is considered as one of the risk enhancer group. So in my practice, even if the patient is diabetic, he's 30 years old, his cholesterols are not very high, I start them on statin. But if he has, like if we calculate a ACVD risk score, his ACVD risk score is high, say between 5 to 7.5%, then also I start. Now, suppose some odd patient comes who has, say his LDL cholesterol is around 110, 120, and when his ACVD risk score also is less than 5%, 2.5 to 5%, then I do a CT calcium scoring. If the CT calcium score is 100, then I start them on statin. So, I mean, in my practice, I am a little aggressive in diabetics compared to the guidelines given by the Western countries, because we see daily patients with MI coming at the age of 30, 32, 28, 35 and all. And so I think if we wait till 40 years in those kind of patients, we are missing the bus. Okay. Anyone else wants to add anything?
What is the target level of LDL? Sir,
Target LDL, see,
70 or 55?
Yeah. I follow 55 European guidelines, but I won't say that all of my patients achieve that. Many a times I have seen with statins patient telling I just cannot tolerate. He'll say I'm becoming lean, my fat is disappearing, I'm feeling too tired and all. So if patients is not complaining of anything, then I try to bring it to LDL of 55. But if patient complains of muscle associated symptoms, then anything less than 70 I accept.
Sir, in ACVD score around 10 and more, you see an young patient, sometimes it's very difficult to convince them to have a lifelong statin therapy. How was your experience with these people, sir? Like,
yeah, because I mean, like we don't have
okay.
Health checkups or those kind of programs here. We see only patients after.
Okay.
So most of my patients are secondary preventions. So I have not had
encountered these groups
convincing a patient for primary prevention. But some odd patient, if I see a young patient and then his son comes to me saying, I also want to get a checkup. Now, then I explain to them. I tell them, see, if your father had taken statins maybe 10 years, 15 years back, maybe this event could have been postponed for another 5 to 10 years. I won't say you could have aborted it, but we could have postponed it. So for you also, but I tell them before starting, I counsel them saying that once you start, it is like you have to take it lifelong. And if you are willing to do that, only you take. Otherwise, you are better off not taking statins and with lifestyle modification.
So one question to Mohan, sir. In pediatric diabetics, what is your age limit for starting statin? Like when you encounter a patient with the risk factors.
Pediatric dyslipidemia, I don't think that.
No, sir, pediatric diabetics.
I don't see.
Pediatric
I
age
see
group.
Only adult population above the age of 18 years only.
Okay.
Now, previously you had to give cholesterols only after 21. Then they made it that even after above 16 you can give. Now, people with familial hypercholesterolemia, heterozygous or homozygous, even we have started at the age of 8. Now, even guidelines say that if patient is having familial hypercholesterolemia, you can even start at the age of 8.
No, sir, familial hyperglycemia, they come to us, but I was thinking the younger diabetics, what is the age?
Diabetes mellitus type 1, we don't have evidence to treat them with statins. I don't think their statins are that high, and it has not been recommended. Usually they say only after 16 or 18 years you can use statins.
So you have shown one of the slide. Like if you stop statin, compared to that, intermittent stopping of statin is very bad. But we see some other patient after initiation of statin, after some time, they say after taking non-vegetarian food, they take statin, say weekly, twice or thrice. So these set of people, how will you convince this set of people? Some say some 20% of people slowly what happens? They totally do not stop. But whenever they take any oil items, they take the statin. Afterwards, they stop for 2 days. Afterwards, they say once in 2 days, they take the statin. For those set of people, what will be your advice?
I will tell them, I mean, it's not that once you take any food, you have to take statin. But I would say if you are, not comfortable with taking statin therapy, at least you can take it twice or thrice in a week, rather than taking it only along with high dose food intake. So I would advise them, if they are not able to tolerate statin, or they are not very happy taking statin regularly, I would advise at least alternate days, or at least 3 days in a week, or even sometimes bi-weekly. That also you have reports and studies showing that even if you take 2 days in a week, it is of some benefit.
Sorry.
Sorry.
No, sorry, proceed, Ali.
Female subset of patients, because we know that females have CAD, they come early in our subset of patient population. So, I mean, it's the same way that we keep, or would you like to add, I mean, bring down LDL cholesterol further down in those type of patients?
Badri, I couldn't hear. The volume was low.
Female subset of patients, coronary artery disease. So dyslipidemia, target LDL, would you like to bring down less than 55 or you want to keep 70?
No, I don't think sex-wise there is a difference in the target. Actually, women, now the incidence of coronary artery disease is increasing. You find more of non-critical coronary artery disease in women. You find more of microcirculatory disease in women. And the prognosis also is bad. The mortality is more for women than in men for coronary artery disease. And to an extent, they are neglected also. In spite of all these differences, I think in guidelines, target is the same for whether it is women or men. You have to achieve the same 55 or 35 based on the guidelines you are following. Target is the same.
Sir, in post-PCA patients, we maintain them on maximum intensity steroids. If for age group of 70, what is your usual dose, sir, for post-PCA patients?
I mean, post-PCA, if it is an after an ACS, I usually start them on high dose statin. I start with rosuvastatin 40 and 10 mg of estimab is my usual combination for any patient going in for PCI. And then after 3 months, when they come, I check their lipid profile. Though there are no recommendations to downgrade statins in future, if patient is not able to tolerate, then I might come down. But otherwise, I try to continue. So
yes, usually there will not be any indicators of muscle disease, but they always keep complaining of this thigh pain and all that. Do you come down with the dose after 3 months?
Yeah, I mean, actually, if you see the studies that what they do is they divided patients with muscle symptoms post-statin therapy into 2 groups. One group, they continued with the statin, and the other group, they changed it to placebo. And what they found was that even in the placebo group, they complained that the number of people complaining were more than the statin group. So then they knew that this is not exactly due to statin symptom. So first thing, I'll try to convince them. But I, to be honest, I have seen in my practice some patients just do not tolerate. Whatever low dose you give, or you try to give them alternate days. Only when you come to the lowest dose, they are happy, they have compliance and they continue. But once you give them high dose, they just don't tolerate. So I have seen that. But most of the times you'll have to convince them or change to another statin or decrease the intensity of statin and give it regularly. So muscle symptoms, I don't just like that stop it. I'll try to convince them 2 to 3 times or stop for some time and re-challenge it. But most of the times I'll try to continue statin.
What about the dosage, sir? If you say a set target, say the LDL level has reached below 70, you down titrate the dosage, or you will as well you manage the same dosage for the particular set of patient?
No, in guidelines there is no down titration for statins. See, once we have started 40 mg of rosuvastatin and LDL are say even 35 or 20, if patient is tolerating and he has no symptoms, then I have no business to down titrate. He has to continue in that same dosage. However, if the patient complains of symptoms, then maybe I'll see the LDL levels, and then usually what I do is, see, when you give rosuvastatin 20 and 40, when you double the dose, the fall in LDL is only 5 to 7 milligrams. But whereas when you add ezetimibe 10 mg, the fall is 15 milligrams. So instead of making 20 to 40, I would rather give 20 rosuvastatin and 10 mg of ezetimibe. I get the same or even better amount of LDL reduction. So then I would use this way. So I would, what I have seen is previously ezetimibe had a negative trial, and then reduce it showed that it is beneficial. So now we don't hesitate to give ezetimibe. So most of my patients, what I do, if they are not tolerating statin, I reduce the rosuvastatin and add ezetimibe and see to it that the same amount of LDL is kept. Okay, so we'll go to question number 4. Okay, now this discussion is about primary and secondary prevention. I mean, now you would have read all about the trials of atorvastatin and all the trials of rosuvastatin. And so do you have a preference for primary prevention? I'll use this statin. Secondary prevention, I'll use this statin. Or you feel that there is enough evidence for both the statins for primary and secondary, so I don't have a preference, I'll use it. I will start with Dr. Badri.
Primary prevention, I would like to start the patient on atorvastatin, calculating whether the patient requires high intensity or moderate intensity statin. For a secondary prevention, I would like to go for rosuvastatin with target area.
Okay. Dr. U.V. Mohan?
In short, primary prevention, definitely rosuvastatin, definitely have been well studied, or usage is more naturally. So naturally for primary prevention, I go for rosuvastatin only. But secondary prevention, there is a lot of trials for atorvastatin. Definitely, cardiologists have taken up atorvastatin in such a big way. Definitely, post CABG or any other complication of secondary prevention, definitely atorvastatin is a drug also, because a lot of trials are backing up with it. So primary prevention, definitely rosuvastatin. Secondary prevention, atorvastatin. That's what my opinion is.
Dr. Nandini, your opinion?
Primary prevention, rosuvastatin will be my first choice, sir. But in secondary prevention, if the patient was already on rosuvastatin, I would go on high dose rosuvastatin. And if it is, I'm going to start newly on the patient, atorvastatin would be my choice.
Good. Dr. Srinivasan, how will you go?
Secondary prevention, I'll take either atorva or rosuva. Atorva means it is 80 and rosuva 40. But primary prevention, I prefer rosuva.
If you look at the trial backgrounds, most of the trial with rosuvastatin has been for primary prevention. The largest trial, Jupiter, also was for primary prevention. And that was also for people with the low LDL and high CRP. And most of the other trials, if you see, they demonstrated that you could reduce the plaque, you could aggressively bring down the plaque volume. And so it was for primary prevention. But atorvastatin has robust evidence in secondary prevention. Like most of the ACS trials were with atorvastatin. But of late now, you are having trials even with rosuvastatin for secondary prevention. So as Dr. Nandini said, if you are already on rosuvastatin, I don't think after an ACS you need to switch over to atorvastatin. You can continue with atorvastatin. But if it's statin naive, then maybe secondary prevention you can prefer atorvastatin. But as such, evidence-wise, if you see, not that rosuvastatin will not work in secondary prevention, but we don't have trials now. Slowly trials are coming up. So I don't think there is much difference. You can use anything. But if you want to go by evidence, then I think primary prevention, one should go for rosuvastatin, and secondary prevention, you should use atorvastatin. Okay, so we'll go to question number 6.
Discussion.
Okay, I think this we have. Okay, some 2 points are there new. I think. Okay, we have that in the subsequent. Okay, this mean platelet volume and arterial stiffness. I think we'll be seeing it in the next slide. Next slide. Okay, regression of atherosclerosis in the carotid and coronary arteries. So this is, I mean, as I said before, decrease in the intimomedia thickness. We have seen more with the rosuvastatin trials. The Meteor trial showed us that when you give this, you are reducing the plaque volume, and you are even regressing the plaque volume by giving high dose rosuvastatin therapy. And the continuation of the Meteor, your Meteor China is going to be conducted with rosuvastatin 20 and 40 mg. So, I mean, like how aggressive you are in finding out ACVD in a patient with primary prevention. Now, like, do you routinely do a carotid Doppler to look for carotid intima media thickness in patients, especially who are diabetic or at high risk, but are asymptomatic. I think Dr. U.V. Mohan, you will be seeing more of this kind of patients, diabetic patients. So do you ask them for carotid intima media thickness?
My level of practice, I can't ask those people, sir. Definitely, that is what depends upon the who have say other states. I'm basically a primary care physician. So,
No, Mohan. Actually, you should be doing this more aggressively. See, we
okay.
are seeing patients after they land up with the MI. I don't see them before. In fact, see, your coronary arteries are 3 millimeters. Your carotid is around 7, 8, or 9 millimeters arteries. So, if you are able to detect a small deposition of cholesterol in the carotid, that will be much earlier.
Okay.
Then that means if in the carotid you are seeing a plaque, that means in coronaries you will have a plaque bigger than that, because smaller arteries it will grow faster. So if you are having a 10% lesion in a carotid, definitely you will have a 30 or 40% lesion in the carotid. So this is indirect evidence that there is same cholesterol deposition in the coronaries also. So I think you should aggressively patient, like if they are sending them for echo, just ask them for carotid intima media thickness of the carotid. You will get it. Once you get that, see patient, his cholesterol levels be normal, you will be giving him only anti-diabetics, his age will be less than 40. But once you see this, you can put them on statin therapy. And definitely it will regress the plaque in the coronaries and help him in the long run. So I think one should be aggressive in this. And already it has been shown that rosuvastatin is able to regress the plaques, or at least prevent the progression of the plaque, which I think it will at least definitely prevent a stroke in the long run.
Okay,
Anyone else is doing carotid intima media thickness? Dr. Srinivasan, at Apollo, you people are doing?
No, sir. I mean, routinely carotid medial thickness is not done, but angle brachial index they do. API they do. Indirectly, the urine micral they see. So enough indirect evidence of atherosclerosis they see. But this carotid medial thickness, it takes a lot of cost, maybe 3,000 like that. So they are not including in the routine packages.
No, I think I mean one should make this as a screening tool, and like ankle brachial index and carotid intima media thickness are surrogate markers for coronary disease. So once you see this, I think you should be in aggressive with statin.
But CIMT is operator dependent, sir, and the cost. That must be the reason we are not doing it routinely.
If you are having a clinic of your own and echo machine of your own, I think you can make it a screening, like something like say even 250 or 500 rupees. You just, I mean, we have seen here, we do for all patients who are sent for CABG, we routinely do carotid Doppler. And invariably we find out, we pick up plaques. But I think all that is too late. And identifying plaque is very easy. It's not very difficult. Once you get used to it, maybe the persons who report from the labs, if they are not doing frequently, their interpretation might not be correct. But I think once you see 15-20 cases of intima media thickness, it's very difficult to miss. So once you identify it personally, I think everyone should try to do on their own and do it at a reduced cost. Or sometimes you can, even while doing an echo, just keep it on the neck if you have that probe, and then take a call. If we do something like that aggressively, maybe we'll catch more primary. Okay, Balaji, we'll go to the next question. Now, reduction of oxidized LDL levels. We all know LDL, normally we measure only the LDL levels, but you also have small dense LDL particles, which you can measure by NMR spectroscopy. If you have more small dense LDL, definitely that patient is at high risk. And that is the MDA LDL, that is monoaldehyde modified LDL cholesterol. These are the LDLs which are already oxidized, and only this oxidized LDL enters the plaque from the blood vessel. So if you are able to detect that the patient is having more small dense LDL, then he is at a higher risk for developing a coronary event. That is one thing. So identifying small dense LDL and oxidized LDL, that is your MDA LDL, LDL which is oxidized. So the size of the LDL and whether it is oxidized or not oxidized definitely helps you to identify patients at risk for an MI in the near future. It is not routinely being done, and guidelines also do not recommend that you should look for whether the LDL is a small dense LDL or a high buoyant LDL, whether the LDL is oxidized LDL. And they have even given levels for oxidized LDL. If it is less than 0.001% of your LDL, it is normal. Whereas in high risk patients, it will be 5% of your oxidized LDL. So, I mean, this is just a theoretical importance, but it has been shown that rosuvastatin decreases the oxidized LDL levels. So thereby it further tells you that when you give rosuvastatin, your oxidized LDL gets reduced and hence your risk for an event MI is coming down. So, I mean, I would like you people to contribute in this. Definitely, we are not going to measure, no lab measures here. But by giving rosuvastatin, we are sure that you are reducing your oxidized LDL level also. It does not reduce small dense LDL. Statins do not reduce small dense LDL, but it reduces oxidized LDL level. Anyone would like to add anything?
Into increase the dose or with the moderate intensity itself reduce.
I mean, yeah, I mean, they don't have a dose correlation, but in this rosuvastatin trials, what they found out was that when you give the oxidized LDL levels come down, but still they have not formed values for oxidized LDL with which you can say that it has reduced to beneficial level. I mean, this is all investigated. Okay, so then we'll go to the next slide. Reduction in lipid-rich necrotic core and plaque stabilization. So that we know, statins in all your ACS trials, that when you give statins, it definitely gave benefit as soon as 1 week after MI. The LDL levels took at least 3 weeks to fall down, but within 1 week you are able to get benefit. So obviously that told that the benefit was not due to the fall in LDL. So that, as I showed you in my slide, was due to the pleiotropic effect of statin. So it passivizes the plaque, it stabilizes the plaque, and it also has an effect on the metallic metallose protein, which helps to prevent a plaque rupture. So definitely, and the lipid-rich core also becomes lesser. That we have seen with rosuvastatin therapy, especially in carotid plaque, which is rich with the necrotic core. There, after giving statin therapy, you see the rich necrotic core disappears and the plaque becomes smaller and stabilizes. So, I mean, this is known. And for rosuvastatin, you have evidence. With atorvastatin, you don't have trials which have shown that plaque regresses. They have not looked into that. Only in rosuvastatin, they have looked into the coronaries through intravascular ultrasound, and then through echocardiography, they have looked into the carotid arteries, and they have shown plaque regression and plaque stabilization. So, your opinion on this? Dr. Srinivasan?
Yeah, every point you have covered nicely, sir. Nothing more to add.
Anyone else would to add regarding regression of plaque?
Higher dose. We have to give high dose statin.
Yeah.
80 milligram and dose of 40 milligram in this patient.
Yeah, we saw in the Galaxy study, all the studies which showed plaque regression were using at least 20 or 40 of rosuvastatin. So it is high dose statin. Definitely, I mean, see, what they have seen is if you bring down, if your LDL remains at 100 to 130, the plaque progresses. If you are reducing your LDL to 70 to 100, then your plaque remains stagnant. It does not increase. Only if you are bringing your LDL to less than 70, then you see plaque regression. So obviously you have to give high dose statin if you want a plaque regression. Okay. Balaji, can we go to the next? Now, reduction in mean platelet volume. Now, this is a new terminology, mean platelet volume. The mean platelet volume, high mean platelet volume means that the platelet has just now come out from the into the circulation. So fresh platelets have more platelet volume, and fresh platelets are recruited when an ACS is happening, because platelets get consumed in the plaque. So this is an indirect indicator. If you have a high platelet volume, it indicates that you are going to have a high chance for developing an acute coronary event. And rosuvastatin has shown that the mean platelet volume decreases when you use rosuvastatin. So this is another indicator that you are decreasing the risk for developing an ACS. So indirect way of saying that this is definitely a good statin for primary intervention. The mean platelet volume has a normal value of 8.42, which increases to 10, 12 in patients who are at risk of developing an ACS. So I think this is just experimental. We are not going to study mean platelet volume for all ACS patients. But this is indirect evidence for us that rosuvastatin works in primary prevention, and when you give, it decreases the mean platelet volume and decreases the risk for MI. So shall we go to the next question? Okay, a reduction in arterial stiffness. So this is also another test where we measure the pulse wave velocity. So what is pulse wave velocity? It is the time taken by the pulse to travel from the carotid to the femoral artery. And this you divided by the distance and multiply it by 0.8. This is an indirect evidence of aortic stiffness. We know if the aortic stiffness is more, then your risk for coronary artery disease is more. So this is an indirect way of measuring the aortic stiffness. And it has been shown that when you give rosuvastatin, they are demonstrated a decrease in the arterial stiffness and thereby the decrease in the event at a later date. So your opinion on this regarding decrease in arterial stiffness with the statin?
Across beta blockers, atenolol has got effect in reducing the arterial stiffness.
Correct.
To central aortic pressure.
Yeah. The ASCOT-CAFE trial showed for the first time that drugs like diuretics and beta blockers do not decrease the central aortic pressure. But whereas drugs like calcium channel blocker and ACE inhibitors and even the newer beta blockers like nebivolol and bisoprolol decrease the central aortic pressure, thereby decreasing the arterial stiffness. So I think in hypertensive patients, along with the antihypertensive drug, if you give a statin, which already trials have shown that adding in hypertensive patients, if you give statin, they benefit. So by decreasing the arterial stiffness, you are also decreasing the risk for CAD in a patient with hypertension. So all hypertensives in primary prevention, if you give rosuvastatin, you are further benefiting by decrease in arterial stiffness. Anyone, anything else to be added? I mean, this is not something which we routinely measure. It can be measured, arterial stiffness, but it is measured only for clinical research purposes and not for a daily routine practice. But since we have the evidence, I think we can, wherever you expect increase in arterial stiffness or increase in central aortic pressure, which we can measure, then I think adding a rosuvastatin will help to decrease along with the antihypertensives that you are giving. Okay, so shall we go to the next question?
Yes, sir. We covered all the points, sir.
Oh, we have covered. Oh,
Yes.
great. So I think each of you can sum up your observation regarding what all you have talked, and if anything you have missed in between you want to express, you can tell. So we'll start with Dr. Badrinath.
In secondary prevention,
Hmm.
I would like to add lower the better, earlier the better, and longer the better. That means we have to reduce the LDL to the lowest, earlier the better, and we have to continue the lipid therapy for long, so that it will reduce the recurrence of event in ACPS events.
Yeah, I agree with you. Because in all the ACS trials, they have shown that when it is started within 24 hours of MI, you get the maximum benefit. In trials where it was started after 5 to 7 days or after 1 month, you did not see that much benefit. And it has, as discussed by all, it has to be continued long. Moreover, you develop ACS in one particular artery in the coronaries, but you will be having multiple lesions in the other coronaries. In due course, sometimes they will also grow and give problems. So I think you have to be on a statin lifelong once you have developed one plaque in one vessel.
One subset of patients, ACS with the peripheral vascular disease, where it has shown that LDL should be less than 40. Very important to reduce a further current events. Highest cardiovascular risk.
Yeah, polyvascular disease is very dangerous. So if you have coronary disease, along with that, if you have peripheral vascular disease or cerebral vascular disease, I think that patient should be eligible for the COMPASS regime. You should give a low molecular, you should give a Novak plus an antiplatelet, because the risk is very high. So obviously there the statin should be high dose. Agree. Dr. U.V. Mogan.
So put in a nutshell, we had a beautiful discussion, sir, whether statins can be used for primary prevention or secondary prevention. What about the diabetic dyslipidemia and all we have discussed in and out. That was really a wonderful discussion. I thank you for initiating and then having a utmost knowledge regarding all these diseases.
Thank you, Dr. Mohan. Dr. Nandini.
Yes, sir. We had a very good discussion. Each and everyone's input was nice. The way you conducted everybody, very good discussion, sir. Each and everything discussed in detail.
Thank you, Dr. Nandini. Dr. Srinivas.
Yes, sir. Everything well taken, sir. And I mean the usage in primary prevention, which one to choose, secondary prevention, how to choose the combination, the combination. So everything has been very well covered. I think you can give the final remarks.
Oh, thank you. So I would like to thank each and every one of you, Dr. Badrinath, Dr. U.V. Mogan, Dr. Nandini, and Dr. K. Srinivasan. And now I would like to hand over to Balaji to do the proceedings.
Thank you, sir. Thank you. Sir, before going into the closing remarks, I'll take this opportunity to present few slides on the Connect to Clinic platform, sir, which is a telemedicine platform which our Alchem has got, wherein it will be more helpful for doctors during the challenging times. Sir, I'll just share the screen where a couple of slides are there about this Connect to Clinic.
Good.
Yes, sir. Yeah, slide is visible now, sir.
Yeah.
Yes,
Sir, yeah. Connect to Clinic is a simple, secure, and reliable telemedicine platform, which is 100% medico-legally compliant, and it is a virtual clinic which is helping the doctor and patients to engage in this challenging times. So, Connect to Clinic, doctor, as I mentioned, it is completely medico-legally compliant. So, it is data safety and security is highly secured. It is as per international standard HIPAA standards maintained, and also we have other features like it is compliant with all the telemedicine consultation guideline of NMC. So absolutely secured, and also patient history. It is very easy to access here, unlike the other platforms, and also payment for the doctor compared with all other platform in the industry. There's a speedy payment with the Connect to Clinic. Within 24 hours, doctor will be getting the payment which has been made by the patient. Also, scheduling part for patients to for doctors to schedule the consultation timing. It is very convenient, and doctors to give the prescription part, both e-prescription as well as handwritten prescription. Connect to Clinic is so very convenient for the doctors, so that easily they can able to generate the prescription, and very compatible for doctors as well. Also, with Connect to Clinic, there is a 24/7 customer care support is there, which can help doctors and patients at any point of time. So currently, there are certain doctors who had been using before platforms which is not available, like doctors were using WhatsApp consultation, but using WhatsApp consultation, that too now the guideline being changed now. So all the data which has been used during this WhatsApp consultation will be under risk, like data like bank account and card detail, also location data, contacts and pictures can be accessed by the application server. Again, the interaction which is happening between the doctor and the patient, and also the diagnostic detail, and also the device and connection specific information, all can be accessed during WhatsApp consultation. So completely the data is under risk. But with Connect to Clinic, which is a simple, secure and reliable platform, which is very completely secured, so it is a better alternative to WhatsApp consultation. And here is the slide wherein compared with all other application, Connect to Clinic features are much more better. First feature, if you see, sir, service charges, it is the lowest in the industry compared with all other platforms. There is only a 6% charges which is being levied by Connect to Clinic, unlike there are other platforms which are much more higher. Also, the patient consulting support videos are there with Connect to Clinic, so that doctors can share those videos, so that patient can easily, again, in terms of complaint part, will be more helpful. And payment option, which I already mentioned, within 24 hours, Connect to Clinic is helping the doctor within speedy by giving speedy payment. Also, complimentary promotion is available for the clinic, and unlike other platform, it is not a marketplace. So it is a unique link which will be shared to the doctor, so that which doctor can share it to the patient, and it is completely secured, and it is not a marketplace. So to understand more about Connect to Clinic, you can doctors, I request you can get in touch with any of our Alchem colleagues who can help you in this regard. So thank you, sir. And sir, I'll take this opportunity to thank all the doctors. Firstly, like to take this opportunity to thank first Eliland sir for accepting our invitation and moderating the panel discussion today. And I like to thank all the panelists, Dr. Badrinath sir, Srinivasan sir, Mohan sir, Nandini madam, for sharing a clinical experience on Galaxy, of experience on rosuvastatin. Also, I like to thank all the doctors who have joined us for today's panel discussion. And I'm sure all the doctors will be appreciating the experience which has been shared by all the panelists today. As such, all the points on statin has been covered. So I like to thank once again the moderator and all the panelists. So at this juncture, we like to salute all the doctors and paramedicals who have contributed immensely for keeping us all safe and healthy in these challenging times. And sir, we at Alchem Laboratories will continue to serve doctors and patients by making our products available, especially Jupiros, Volcom and Globilda. So thank you, sir. Good night, sir. Thanks for the opportunity which has been given to us, sir. Thanks, sir.
Thank you. Thank you.
Thank you, sir. Thank you, sir. Thank you.
Thank you, sir.
Thank you.
Thanks, Eliland sir.
Thank you.
Thank you, sir.
Thank you, sir.
Thanks, madam.
Thank you, sir. Thanks, madam.
Thank you, sir.
Thank you, sir.
Thank you. Thank you. Thank you.